Okay, great. So, good evening, everyone, and welcome to another webinar on no thrombosis, which is an initiative taken by Genova talking about interesting cases in the field of stroke. So, with this, it's a pleasure to invite our course director, Dr. Icha Puria, sir. Sir is the director of neurology at the Sayadri Hospital, Yerwada. Of course, sir doesn't require any introduction from our end. It's a pleasure to have you here, sir, today. Sir is the first neuro ICU and neuro intensive care unit of Pune. Sir has established that. He has been a pioneer in thrombolysis treatment for stroke in India. More than 300 public lectures and workshops on stroke he has taken. Sir is a member of Indian Stroke Association and the organizing president of StrokeCon 2012 and the organizing president of ISA's Stroke School. Sir is a founder of the Pune Stroke Group as well, ex-president of the Society of Neurosciences Pune and Maharashtra Academy of Neurology. Sir is a principal investigator for multiple multinational stroke trials like Perform, BrainsGate, BG12, cortical venous thrombosis, Interact, etc. Sir has also been awarded as a health icon by the Times of India Group. So we welcome you here, sir, today. It's a pleasure to have you. With this, we also have our moderator, Dr. Just a second, sorry. Dr. Rahul Baviskar. Sir is an MD DM Neurology and a consultant neurologist at the NeuroCare Clinic, Nashik. Sir did his MD Medicine from St. GS Medical College and KEM Hospital, Mumbai. He was a recipient of the Prabhakar Sadle Memorial Gold Medal for standing first in MD Medicine students. He did his DM Neurology from TN Medical College and BYL Nair Charitable Hospital, Mumbai. His specialty interests are management of headache, epilepsy, stroke, dementia, and multiple sclerosis. He is also a principal investigator in clinical trials involving epilepsy, stroke, Parkinson's disease, headache, and multiple sclerosis. He has presented various posters and papers on national and international platforms. Since last 13 years, he is practicing as a consultant neurophysician in Nashik. He's also attached to the DUI Dr. V.N. Pawar Medical College in Department of Medicine. So it's a pleasure to have Dr. Rahul as well with us. With this, we move on to our second moderator, Dr. Prasanna Kasegaonkar. Sir is again the chairman and consultant neurologist of CNS Hospital, Solapur. Sir is a member of the American Academy of Neurology, Indian Academy of Neurology, Maharashtra Academy of Neurology, the Association of Physicians of India, and the member of the Indian Academy of Physicians, Solapur chapter as well. Sir has total 22 publications and papers which he has presented on national as well as international platforms. Sir also has a lot of teaching experience, nearly about 5 years in the Department of Pediatrics at Dr. V.M. Medical College and CSM General Hospital, Solapur. Sir has been awarded the Healthcare Professional of the Year 2017 in Neurology, the Luminaries Award in 2018, Dhanvantari Ratna Puruskar in 2018 again, and the Aadhar Maharashtra Bhushan Puruskar in 2018. So it's a pleasure to have Dr. Prasanna also with us. With this, we move on to our esteemed speakers. The first is Dr. Pramod Dhonde. Sir is an MD DM Neurology, consultant neurologist and director of the Dhonde Hospital and Shivansh Neuro Rehabilitation Center, Nanded. Sir has been working in the neuro rehabilitation field with the start of highly advanced Shivansh Neuro Rehabilitation Center at Nanded, with facilities for patients, hydrotherapy in various modalities, with teamwork since 2 years, working as an environmentalist as well since last 6 years, with tree plantations, with maintenance, rainwater harvesting across Nanded city, and awareness programs for the same. Sir has multiple publications under his belt, like the chronic dysimmune neuropathies, Annals of Neurology India in 2011, spinocerebellar ataxia in the Western Indian experience in the Neurology Asia 2011, and multiple more like the COVID-19 and mucormycosis, stroke, and CVST, which again contributed as a co-author in national publications. Sir has presented in tournament. Please keep yourself on mute, Amit.
इसको ही ले ले हाँ विशु ये वो ले ले बाहर, विशु वो पास्ता या रख दो वहीं
Ankit, could you please keep yourself on mute? Yeah. Sir has presented in tournaments of minds at WCN Kyoto 2016 as well, and various poster presentation in national as well as international conferences. With this, we come to our final esteemed speaker, Dr. Anirudh Deshmukh. He's a MBBS MD DM Neurology, a consultant neurologist at the Kailash Hospital, Noida. Sir is an experienced neurologist specializing in stroke and interventional neurology with expertise in advanced diagnostic procedures and management of neurological disorders. Sir is adept at performing complex interventions such as mechanical thrombectomy, angioplasty, and stenting. Sir is also committed to providing high quality patient care and contributing to advancements in neurology through research and publications. With this, I invite the forum to discuss regarding interesting cases in stroke, and over to Dr. Chapuria sir to set the context and hand over to our speakers. Over to you, sir.
Thank you for the kind invitation, Ronak, and the introduction. I think the moderators have not yet joined. So I think we'll go on straight to Dr. Pramod Donde's case. Pramod, will you take your first case?
Yes, sir, surely.
Yeah.
And thank you, sir. So at the outset, I thank Team Genova.
Little loudly.
Yeah. Am I audible?
No, very, very faint.
Am I now?
Speak up, we'll see.
Hello? Hello?
Yeah, now you're better. Maybe you can come closer. Yeah.
Thanks, Team Genova, for giving me the opportunity to talk on this interesting case presentations in no thrombosis program. Initially, I have presented one case last, I think, 2-3 years ago of central retinal artery occlusion with tenect place. I have presented one case. Hello? Is it audible, sir, now? Hello?
I think just come a little closer because it's very poorly audible.
Hello?
Yeah.
Yeah. So I'm going to present one interesting case which has a little bit of out of boundary for IBT being a non-interventionist strokeologist. So this is one of the interesting case presentation and one of the rewarding results which I have found. So let us go to the case directly. Am I audible, sir?
No.
I will just share my presentation.
We have to strain to hear.
Yeah, 1 minute. My presentation is visible?
Yes.
Now am I audible?
Yes.
Okay, sir. So this is one of the interesting case which recently I have shared on one of the platform on stroke group also. So let us go to the case directly. This is a clinical versus radiological diffusion mismatch. Are we missing cases? So this is one of the case which I'm going to present. So case is a 32-year-old male, non-diabetic, non-hypertensive, presented within 6 hours of stroke with right hemiparesis with dysarthria with NIHSS of around 14. On examination, patient's vitals were stable with BP of 130/90, power right upper and lower limb grade 1/2 in right upper and lower limb with significant dysarthria. Patient already came with the MRI brain screening as versus which showing partial versus non-partial diffusion weighted flare mismatch. So I will show the directly MRI. If you see in the MRI, first one image is the flare image, which is showing changes in the left posterior cortical occipital region, which is corresponding with this flare changes are also there, and there is some diffusion restriction in the similar area. As patient was young and patient was having this deficit of significant deficit, though we have thought that we should go for this thrombolysis. Despite the no partial mismatch or out of window period, IVT was done with tenecteplase and the dose was given as 0.25 milligram per kg at 6 hours. And patient made remarkable recovery next day in speech and lower limb. And at the end of 1 month, he is absolutely fine. On etiological evaluation, his 2D echo, neck angio was normal, blood parameters were normal. And so it was undetermined young stroke, that is, or ESUS. That was the etiology in this stroke probably. So this is the next day CT scan, which is showing this changes on the left side occipital cortex, as well as in the some areas of this MCA distribution. and his angio was remarkably normal, and his even neck angio was also normal. So in this case, questions arise that there are two things which I found it a little bit interesting and intriguing. For young ones or older ones also, time window, is it necessary strictly 4.5 hours? We'll try to find the answers by showing some slides with this. And second is the DWI flare mismatch versus clinical DWI mismatch. What's more important? So these are the two questions which I'm going to try to answer with the next presentation. So this is one of the trial which has been shown that, so I'm not going to talk about the mechanical thrombectomy part. This is strictly related to IVT, that is intravenous thrombolysis. So this is one of the trial which has been published, thrombolysis for ischemic stroke beyond the 4.5 hour window, a meta-analysis of randomized clinical trials. So the recent trials have demonstrated MT efficacy even in the extended time period, which has been proven beyond doubt now. However, in many geographic locations, including developed countries, timely access to MT is not feasible, and it is often unavailable in the low or middle income countries. In my city also, it is very difficult to send the patient within time frame of 6 hours or even within 24 hours. Consequently, IVT remains the sole option available for a significant proportion of patients of global population suffering from acute ischemic stroke. So these are the various trials. These are 8 trials which has been including around 816 patients with this. The first is the Exit BT that is published in 2024, which included number of patients 12 and which is used with tenecteplase. Then second one is the Extend trial, which is including multiple centers from Australia, New Zealand, Taiwan and Finland. The number of patients are around 30. And the Epithet trial that is in published in 2014, which has used alteplase. In the Extend trial, it has been used is alteplase. ICAS-4, which has been used in European subcontinent and which has been used with alteplase. Then this is Wake Up trial, which has been, this is one of the important trial and which has used alteplase. Then Rose TNK, Trace 3 and DOS trial, these are used tenecteplase. In THOS trial, it has used alteplase. So these are the various molecules which has been used in these 8 trials. So I will go to the next one. So characteristic of the intervention is that Exit BT, this is the radiological eligibility criteria I'm going to talk about. This is more of a confirmed acute ischemic stroke on a CT scan or MRI, and the time window period was 4.5 to 6 hours. And this Extend trial, which has used MR perfusion or CT perfusion, the time period was 4.5 to 9 hours. While in Epithet trial, there was no eligibility criteria band based on perfusion diffusion MRI mismatch, and the time window period was 4.5 to 6 hours. ICAS-4, which has used that perfusion based imaging 4.5 to 9 hours, while Wake Up, it has been more than diffusion with a high signal and visually normal flare, that is a diffusion weighted mismatch is there if it is more than 4.5 hours. And Rose TNK, which has 4.5 to 24 hours, which has been published in 2023. And Trace 3, which has used as MRI or CT perfusion based, and the time the patient has been thrombolized with way up to 24 hours also. And THOS trial, which has more than 4.5 hours, this is diffusion weighted with this is diffusion flare mismatch, which has been used in THOS trial. So the conclusion is that the main finding of this meta-analysis is that compared with the standard medical care, IVT significantly improves the rates of excellent and good functional outcomes at 90 days, although at the cost of a greater risk of SICH, that is a spontaneous intracranial hemorrhage, and a non-significant increase in the 90-day mortality. The diffusion-weighted flare mismatch was used in Wake Up, THOS and Rose TNK trials, offering a straightforward method for identifying eligible patients through visual assessment of magnetic resonance imaging sequences. So these 3 trials have used diffusion-weighted image flare mismatch. Then in contrast, perfusion image used in the Extend, Trace 3 and ICAS-4 trials was image post-processing but can identify patients with a viable tissue even in the presence of marked hyperintensity on the flare. So these are the trials which has used perfusion imaging. So there are 2 ways where you can extend time frame, either it is diffusion-weighted flare mismatch or a perfusion imaging. So conclusive evidence regarding the validity of diffusion-weighted flare mismatch is challenging because 2 trials employing diffusion-weighted flare were terminated prematurely. All of the 3 trials, only the Wake Up trial, which included a large number of patients, found a significant benefit in achieving excellent functional outcomes at 90 days, while the Rose TNK and DOS trials have found no significant benefit. So this is the sub-criteria which I'm going to show. Diffusion-weighted flare mismatch sub-analysis. Primary outcomes, MRS score 0 to 1, that is 1.34. 0 to 1.28, while CT perfusion sub-analysis, it has shown that 1.45, that is MRI score of 0 to 1, that has been achieved. So diffusion weighted flare mismatch versus CT perfusion, it is 1.45 versus 1.34, that is odds ratio of achieving significant outcome. While alteplase and tenecteplase sub-analysis, it is shown that MRI score of 0 to 1, it has been achieved 1.47 versus 1.38. That is better with tenecteplase as compared to the alteplase. Not very significant, but still it is better. It has been shown in the sub-analysis. So this is the first question, which is that diffusion weighted flare. The first question is that it is definitely beyond 4.5 hours up to 6 hours, up to 24 hours also. If based on perfusion based imaging, you can thrombolyze the patients if there is viable tissue on the perfusion, or if there is significant diffusion weighted and flare mismatch is there. Are the current MRI criteria, this is another concept which I'm going to talk about, are the current MRI criteria using the diffusion weighted flare mismatch concept for selection of patients with wake-up stroke to thrombolyze, excluding too many patients. This trial, actually this is only 10 cases are there, but it's very interesting thing to know that in this trial they have thrombolyzed, if there is diffusion weighted flare match is there, they have thrombolyzed around 6 patients, and in those patients they have found significant benefit also. So this is the patient selection that has been shown, and mismatch versus match, and it is shown that it has been 2 patients have worsened while 4 patients have shown significant improvement, and this is the NIHSS at discharge 5, 2, 0, 1 in this match group, while the mismatch group it is 11, and this another one is NIHSS at discharge is 1. So this is very significant. Only few cases are there. Still, this is one of the important trial to understand. Still, we can thrombolyze if there is diffusion weighted flare match is also there. Why it is there? I'm just going to talk about that. So this is one of the pioneer article published in Lancet Neurology, where diffusion weighted flare mismatch this was the criteria which has been used, that within 4.5 hours we can identify this viable tissue, and this was a trial which a pre-flare trial, and this has been shown that the diffusion weighted flare mismatch identified patients within 4.5 hours of symptom onset with 62% sensitivity, 78% specificity, 83% of positive predictive value, and 54% of negative predictive value. 54% of negative predictive value means that 54% of the patients have matched within 4.5 hours of stroke onset. So still there are chances which we are going to miss with this diffusion weighted flare mismatch. So this is not very 100% true that this can be used as a substantial criteria for thrombolyzing patients. There is another concept which is called clinical diffusion weighted mismatch, a new diagnostic approach to the brain tissue at risk of infarction. What is it? What does it tell that? It is an acute stroke patients with an NIHSS score of more than 8 with diffusion weighted volume of less than or equal to 25 have a higher probability of infarct growth and early neurological deterioration. This new concept of that is a clinical diffusion weighted mismatch can potentially select those cases where there is chances of that you can find the brain tissue at risk of infarction, and you can these thrombolyze patients at ease also. So this was in 2005. This was in 2004. Again, this is 2020. Actually, these are the reliability of clinical diffusion weighted mismatch approach to predict patient with probability of large infarct growth. A comparison of percentage of infarct growth and clinical diffusion mismatch status of the patients with acute ischemic stroke. What does the results of this trial show? That CDM was present in 36% of our patients and was associated with the percentage of infarct growth. The mean percentage of growth was high in patients with CDM, that is almost 211%, while it was low in the group of patients without CDM, that is 5.7%. The sensitivity and specificity of CDM to predict infarct growth was 77.8% versus 100% with a likelihood ratio of 15.4. The approach of comparing CDM and percentage of infarct growth proved that the concept of CDM can accurately indicate the existence of a large volume of tissue at risk of infarction, that is penumbra. So this reliability of this, definitely this clinical diffusion weighted mismatch has to be in the practice also, because this can identify many number of patients we can thrombolyze with ease also if we can find out these patients on the MRI as well as based on clinical as well as MRI criteria. With this, I would like to end my talk. If there are any questions, and I would like to learn from sir also that what is your opinion about these kind of things when these kind of tricky cases comes up in the field. Hello.
Yes, Pramod.
Yeah.
Yeah, it's a very nice presentation and very good review of the literature. Uh, I think Rahul Baviskar has joined.
Yeah.
Rahul, would you like to comment?
No, I think this concept of clinical and diffusion weighted mismatch will help us to identify many more patients where we can go beyond the window period. Our aim should be give maximum benefit to the patient, and I think it will definitely help us to manage this patient more effectively. Only one issue, Pramod, I just wanted to, in this particular patient, you told that the patient showed improvement the next day.
Yes,
Whatever
sir.
we say that the whatever thrombolysis benefits we see, sometimes which are immediately after the bolus dose. So how can you definitely say that the effects were related to thrombolysis in this particular case?
Actually, sir, patient was thrombolized within 6 hours, and the patient started improving slightly at the time of after the thrombolysis immediately. But the next day, his lower limb improvement was there significantly, but still there was some partial improvement. There was not much of improvement in the upper limb, and speech has significantly improved. So there was some partial deficit was there. So still it is related to thrombolysis, because if if it would not have been thrombolysis, your patient would not have improved in that way.
Okay.
And his stroke, if you pattern the pattern of stroke, is that it is a patchy infarct, that is a patchy infarct in the watershed distribution. So most likely some emboli is there, and how it is that we didn't give anything else other than that, so it is definitely related to that only.
No, this improvement can occur up to 3 months also. It's not
Oh,
that
yes,
it has to occur immediate. Immediate improvement occurs in about 20% of patients.
yes.
That is called VENI, very early neurological improvement. That is, when the embolus dissolves completely and the blood flow is restored. But what trial has been, the trials are MRIs at 3 months.
Yes, sir.
So the improvement occurs progressively. It can occur up to 1 year also. And in fact, those patients who have been thrombolized, their quality of life improves compared to non-thrombolytic period, even at 1 year. So it's not that it has to occur immediately. Yes, about 20% occur immediately, but many take some more time, because there is this concept which I like very much, of called brain stunning, like how myocardial stunning is there. Uh, that area is ischemic, and it takes some time for it to improve. So, I mean, it can occur in days, weeks, months. So, and all the trials have shown that thrombolysis is beneficial even at 3 months. In fact,
Trials.
the first trial did not talk about early improvement. They talked only about improvement at 3 months. We are seeing it now, early improvement.
Yes.
So it continues to occur, and it gives benefit even over the medium to long term. So it does benefit patients in that way.
I
With all
totally
the
agree.
trials, we
Totally
generally
agree
see.
with that point. My
Which
issue is
point?
the only thing when the immediate improvement occurs, it becomes very easy to attribute it to thrombolysis.
Yes, yes, yes. See, now in an individual patient, you cannot attribute.
Yeah.
But when you take a cohort of patients, then more likely you are going to improve with thrombolysis than without thrombolysis.
I agree.
So this is when you take a cohort. But when you take an individual patient, to say that this thrombolysis did not work here or did work here, impossible to say. Impossible. So when you take a cohort, the cohort definitely has shown. I mean, there are so many objections, so many objections. Even Kaplan, for that matter, was against thrombolysis for 7 years after the NINS trial. He was vehemently, vociferously against it, you know. But then it has stood the test of time, and uh, we find remarkable changes in patients. Uh, there are some things we cannot measure. We only talk of motor and sensory and speech, but cognition, very important, very, very important. Cognition improves, quality of life improves, dependency improves. So there is no doubt now that the improvement can occur over a period of time, and it is certainly beneficial.
Just one
Now,
question.
I think it's a very important point you brought out, Pramod.
Yes.
I am not a great advocate of this very strict time window. I've
Yeah.
become very loose now. And, this 4.5 hours. And I mean, yes, if you see those curves which were drawn by Kennedy Lees, they showed that after 4.5 hours, the improvement did not occur. But if you see the curve, that was the average. There were outliers. There were outliers which did well even later on. And there were outliers which did not do well even at 4.5 hours. So there is a fairly large, 4.5 hours is the average time. There are many patients who improve even at 6 hours and 8 hours. Now, recently, this trial done by the Chinese called the Timeless trial, they have given intravenous thrombolysis up to 24 hours and they have found improvement. Of course, they did perfusion scans. Now, it's very difficult to do perfusion scan in most places of the world. Most places of the world, you cannot do perfusion scan. Even we are struggling with this perfusion scan and, to interpret it and whether it's really representative of what is happening is still open to question. So I don't do perfusion scan. If I find a patient, and what you said very nicely, I must say, of clinical radiological mismatch. Now, when you do CT scan, you always find mismatch. The power is zero and the scan is totally normal.
Yeah.
So now that doesn't mean that you should do an MRI. You can do a CT scan. CT scan, so always it shows a clinical radiological mismatch. Always, always.
So you're
Aspect
saying
score.
that,
Sometimes
yeah,
you cannot, the scan, 60 to 70% of CT scans in acute ischemic stroke are normal scans. Even with the trained eye, even if you look at the aspect score very carefully, you change the setting of the CT scan. 60% of CT scans done in the early period are normal. So it's clearly a mismatch. And what a stroke is a clinical diagnosis. You're seeing a patient with low power with a normal looking scan. Clearly, it is a clinical radiological mismatch. And why should you see the infarct? There is no need to see the infarct. You see a patient who has got hemiparesis or deficit, and scan is done not to see the infarct. The scan is done to rule out mimics.
yeah.
And if you don't see that, you can thrombolyze.
If
So,
the
so where's the
mechanical
question?
thrombectomy window has been extended by dawn and trial up to
Yes, yes.
24 hours, so why not IV
It is
thrombolysis with both
extended. It is
recanalization?
See, this thrombectomy in low and middle income countries is accessible to 2.8% of the population. 2.8%. So 97% of the world's population, not world's, 97% of the population in low and middle income countries has no access to MT. So we have to use IVT. And we must use. Why not?
I agree.
Why not? So I'm a great advocate of this extended time window for IVT. I'm not so strict about this 4.5 hours. At 4.5 hours, everything stops. ऐसा कुछ नहीं है. So you can easily give. Pramod Dhonde has shown very clearly that infarct was small, deficit was large. Okay, that flare showed. So what? Flare shows only a part of the infarct. Diffusion also shows only part of the infarct. There may be an area which is ischemic, which is not infarcted. So that part has improved.
Yes, sir.
So MRI may show you, and diffusion may show you only a part of the infarct. It may not show you the whole infarct. So if you're confident, if your blood pressure is okay, other things are okay, I would not be over strict about this 4.5 hours. Okay, this fellow at 6 hours, and number of trials have shown that 6 hours, 8 hours, 9 hours, people have improved. And access to mechanical thrombectomy is limited to large cities. Even in large cities, it is not easy. It is expensive. It is very time consuming. It is, lots of resources are required. And many people in the world, as I told you, only 2.8% people in developing countries can use it. So why not use IBT? Superb. Some will not improve. If it is a large vessel occlusion, it will not, but others will improve. And even large vessel, 30% may open. So why not? I mean, for our country and this thing, though I'm in a fairly large city, it's not the largest, it's a medium-sized city. Even we are having problem with mechanical thrombectomy. I mean, people don't have money. They don't come in time. The resources are limited. So though we would like to do it, I don't think we should deny anyone IVT even in the late window period. To do perfusion scan is difficult, and this flared DWI mismatch is a good surrogate marker. It's a poor man's क्या बोलते poor man's perfusion scan, or you can do an ASL, the arterial spin labeling. And there, if you see that there is a large area of hypoperfusion with a small DWI lesion, that is also quite good. So we have to be innovative. We cannot totally follow Western standards, and we have to give the best to our patients who really require this. And that's my view. Pramod, what do you have to say?
Actually, sir, we should take a trial of clinical CT mismatch rather than DWI. Because what this trial, last slide has shown that the specificity of clinical diffusion mismatch is almost 100%. So we should take a trial of clinical CT mismatch also. If
Now
there
you
is CT
see, Pramod, now everyone may not have access to MRI. If
That's
you
what
have
I'm saying,
CT
sir.
scan, almost 60% will have CDM.
Yes, sir. Yes, sir.
So
That's what.
उसमें तो
That's what. Why not to
why do you
normalize
want to
those
deny?
patients?
Why do you
Yeah,
want to deny? Okay, if you have MRI, fine. It takes a little more time. It wastes a little more time. Sometimes today I had a patient. It was impossible to do his MRI. Impossible. He was so restless, so irritable. We gave him midazolam, lorazepam, Serenase. That fellow would not sleep only. So it's not easy to do an MRI. If the patient is cooperative and all, yes, certainly use it, especially in the late window period. But why should you do flare diffusion mismatch at 4.5 hours? It is ridiculous. No need to do.
yeah.
Why do you need to see diffusion flare mismatch at 4. You showed one trial, no, at 4.5 hours. You don't need to do that. You do it only in the late window period and use it as a surrogate marker of perfusion scanning. Perfusion scanning, even in the best centers, is difficult to do and difficult to interpret. That is my personal experience. There are some radiologists who are very confident about it, but somehow I'm not very confident about it. And what it really shows you may not be replicated. So I rely in the late window on flare diffusion mismatch. And the original paper said that nothing should be seen on flare. But now we are extending it. When many people are extending it, flare, if it shows little bit also, and diffusion is bigger than flare, it is still a mismatch. It may not be a complete mismatch. Why? The trial was done for complete mismatch. But if it is a partial mismatch, why not thrombolize these patients?
Yes. Absolutely.
This is my view. Now, why should you do it in 4.5 hours? It doesn't make sense. So these patients, you just you rule out a stroke mimic, rule out hemorrhage, and fatak, just give the tenecteplase, and that's the end of the matter.
Yes. I think this
And
clinical
I don't
mismatch
know
is.
in Nanded whether you can do mechanical thrombectomy, but it's not easy to do it. It's not easy. You have to have a trained person, and that person has to do it many times, to get proficiency. If he does say one per month, he doesn't have the proficiency to do it. He must do at least 5 to 10 per month. Now, how to do 5 to 10 per month? I am struggling to do five patients per month. अभी इतना पैसा ही नहीं है किसी के पास to do it. So how do you become proficient in mechanical thrombectomy? You have to do it again and again and again. If you do once in a month, sorry, you don't get the proficiency. So therefore, I think in our country and in our setup, I rely a lot on IBT. I'm not too strict about 4.5 hours. And you have clearly shown that, 6 hours, 7 hours, it works. It works. So what do you say, Rahul?
Fully agree with you. I think if we don't have access to mechanical thrombectomy that easily, if we have proof that mechanical thrombectomy works up to 24 hours with Dawn and all those, and the principle is recanalization, why not?
Yes. And you see, Dawn and Diffuse, it was highly selected cases.
Correct.
Out of, say, 10 patients who came in the 6 to 24-hour window, they took only 1 or 2 out of those 10.
Correct.
And why did they do that? Because they wanted to make the trial successful.
Successful.
So now we are extrapolating. Now we are saying that even if aspect score is low, we are not using the Dawn diffuse criteria of small core. Even if there is a large core,
Go ahead.
these patients are benefiting.
Absolutely.
They are benefiting with MT, and therefore they are benefiting with IBT. May not be to the same extent.
Correct.
MT, they will benefit more, no doubt about that. But with IBT, 30% will benefit. 100%. Even with with mechanical, 100% are not going to benefit. It is only 1 in 4. 1 in 4 is going to benefit. And to say that diffusion if you're seeing a lesion like this, it is irreversible, that is also wrong. We have seen diffusion lesions also regressing.
Correct.
So diffusion lesion does not mean that that area is infarcted. The core may be infarcted, but there may be a surrounding area of the diffusion which is still alive. So, our concept was that diffusion means it is dead, or flare means it is dead. It's not so. It's not so. There are areas in the diffusion, there are islands, there are areas which are not uniformly supplied by blood. So they do improve. So what I'm trying to say is that in a large part of our country, use it even in the late window. Be a little careful. Don't be foolhardy. And use it because, see, it's difficult to do MT, difficult to transport the patient within 1 or 2 hours to a big center. And that big center also has to have the capability. It's okay in America. Even there, they are struggling. It's not that they are okay. It's not that. Only 10 to 15% of eligible patients of MT get MT, even in highly developed countries. In low-income countries, it is 2.8%, which is a pathetic figure. I just looked it up yesterday because I was preparing some data. It's क्या बोलेगा 2.8 is really a sad figure, but that is the ground reality. Is it the ground reality, Pramod, in your area?
Yes, sir, yes, sir. We don't have that intervention thing
Yeah.
also.
So large parts of the country, India ke chodo, in large parts of country in America don't have.
Actually, cost is a very big issue, sir, here because
Yeah,
people
it's
don't.
a big issue. And see,
How can suddenly say
these
that?
trials, no, these trials which were done, they were done in Holland. This Sapna, that main trial, what was it called? Anyway, that main trial which was done in Holland, it is a small country. It is the size of Goa. It is flat. There are no hills. You can transport the patient very rapidly within half an hour from one end of the country to the other end of the country. And the medical facilities are there at every half an hour. We are not in that situation. We don't have that much good road transport, aerial transport, facilities every half an hour. We don't have that. So these trials showed, but how to replicate it in the real world? That is the big challenge for us. How to develop accessibility, affordability, and availability for our patients. That is now our challenge. Okay, the trial is done in a developed country. It has shown benefit, no doubt about that. We don't doubt it. We are not questioning the trial. But now we have to translate it to our situation. And that is a challenge.
And sir, in a lot of these countries, healthcare is covered by government. You go to
Yes.
Australia, everything is paid by government. You do in
Absolutely.
Holland, and so
Yeah, so
you cannot directly
अपना problem तो
replicate.
totally different here. Our
Yeah,
problems are totally different, and but we are doing well. Still, we are doing well.
true.
Uh,
Yes.
still, we want more people to do it. Still, the rates are low. We are doing, say, maybe.
But even there, sir, in MT recent trial, Angel from this was from China. This was 26% in MT, and then they had to do intra-arterial tenecteplase, and then the MRS score increased to around 40 or something. So, as you rightly said, I mean, it is not like MT is the Amrit hai kuch de
MT
diya,
works
so
in
it is not. It is just
in 1 in 4.
yes.
1 in 4.
Yes.
If everything is right, he comes in time. You can remove the clot quickly
Mhm.
in 1 or 2 passes. Then fine, they do very well. Amazingly well, they do. Amazing. We have seen remarkable improvements, but we've seen remarkable failures
Eh,
also. So, yes, we will push hard to do it in an eligible patient, but you have to be careful that it's not 100%. Nothing
And
is
then
100%.
the care there. I mean, if they have these retirement homes, other things are there which are not available in India. I mean, there
See,
are,
see, we don't have good neuro ICUs.
yes,
We have general ICUs with general intensivists. They don't know much. I mean, they don't know, I wouldn't say much. They don't know enough about cerebral treating neurological patients. So, infrastructure ka bhi problem hai. You have to have in-house CT scan, in-house ICU, in-house trained staff. So it's a major challenge.
and these
Not that we are
4.5
not
is,
able to face these challenges. We
and
are,
it is with
and we
somebody,
are
we did
winning.
the trial at 4 point, so it comes 4.5. If we did trial at 6 hours, we'll say yes, it is useful up to 6 hours.
Yeah.
So,
See, previously, this NINS trial, no,
mhm.
it had to succeed. It
Yes,
had to succeed. So
yes,
they did it in 3 hours.
yes.
Even that, there was so much controversy. Ki you took only how many patients they took? They took very few patients. Some,
167,
huh?
167 patient in
167. So everyone was very critical. कि अरे यार 167 patients में 3 hours. It was impossible. How to replicate this in the field? That trial was published in 1995.
Mhm.
ICAS 3 trial took 13 years. 2008 it was published for 4.5 hours. 13 years it took. And even then they had so many caveats. Now all those caveats are removed. So as we are going along, this 4.5 is going up to 6, it's going up to 24. These Chinese, they have done
Although Chinese का
remarkable
sir
work.
थोड़ा data trace कर,
No,
I mean, we
no,
have to
no, sir.
replicate in
No,
Indian
no, no,
population.
no, no. Chinese have done very good data. They
Mhm.
have done very good data. Don't say that they are bad. They have done fantastic data. The Americans always say that, oh, their data is all bakwas. And they replicate the trial and they found that the trial has stood the test of time. So, and the Chinese have done remarkably well.
We never
So,
know where some more new thrombolytic agent may come, which is very clot specific and
yes.
cause full
So many things may
recanalization.
happen, yeah. So many things. It is not the end of the road. See, time
Correct.
is one thing. New agent will come. New vessel remodeling will come. Something will come here. Cerebral protection will come. Neuroprotective agents will come, which you give along with the thrombolytic agent. So, brain which is dying can be supported. So,
Salvaged.
the field is enormous. And I think our role is to make things simple, to give maximum benefit to maximum people, not be so rigid about 4.5 and 5.5 and 6. And ठीक है, the trial was done for 4.5, but ठीक है, Pramod Dhonde has shown clearly that 6 hours, and other trials have also shown 6 to 24 hours, 24 hours IV thrombolysis. So use it as per your common sense and discretion. Don't be over rigid. कि flare में niche दिखना चाहिए. Who said? Little bit of flare is okay. You can still give, you may not give 100% benefit. You may give 80% benefit, but still it's a benefit. Fellow who was bedridden, if he walks, enough, man. Enough. You don't have to make him run 100 meters. If he is independent, it is a big advantage to the family at very, very little cost.
This case has definitely given me the confidence of clinical
Yes,
diffusion.
Pramod?
This case has definitely given me the confidence for this selecting criteria based on clinical diffusion weighted mismatch or clinical mismatch.
There is no doubt. I'm very glad that you brought this up because you see, people are so rigid about the time, and this is one of the enigmas of stroke thrombolysis. Should we be so rigid about time? So it's very nice that you brought it out. That yes, we want to be careful. We don't want to produce harm, but we still at the same time cannot be over rigid about time.
Yes.
So I think it's very nice that you brought it out. Any last words, Rahul? For
I think Prasanna has joined. Prasanna.
Where is Prasanna? I can't see him.
Yeah, I think he's visible.
Yes, sir.
Prasanna.
Good
Prasanna
evening.
has been a regular feature of this program.
I love these programs.
Third or fourth time he's here.
Yeah.
And I think we enjoy his company.
Yeah,
And I
absolutely.
think he also enjoys it. Rahul, I think, has been for the first time or second.
This is second or third.
Second time. No, it's a very good program. And Pramod, thank you for bringing up this point of clinical mismatch and late time window. I think it's a great advantage to many people.
Thank you, sir. Thank you.
Yeah. Shall we take the next case? Aniruddha?
Yes, sir. Good evening, sir.
Good evening.
Yeah, sir, I don't have a separate presentation. They told me the last moment. But I would like to share some cases which, including some thrombolysis and thrombectomies, which we have done previously.
Yeah.
So I want to talk about this small vessel lacunar infarcts in either anterior or posterior circulation, where patient comes with dense hemiplegia and a small infarct, even within window period. Many times we don't see an improvement in our thrombolysis. And whether it is internal capsule or medullary or that pontine strokes, the penetrating branches of pons. So we've initially we thought that all these small infarcts, which are end artery infarcts, which have no collaterals, and once they set in, even thrombolizing or trying to open it up doesn't really give much of improvement, especially the basal ganglia infarcts. But sometimes we've seen that after thrombolysis, some of these medullary and pontine infarcts don't progress as compared to when we don't thrombolyze these patients, either due to at the end of window period or lack of funds. They tend to progress over next few days or few hours, maybe that a small medullary infarct which came with mild dysphagia goes into total quadriparesis and later into complete dysphagia and goes on a tracheostomy. So, sir, I want to know what is your thoughts on these cases of small lacunar infarcts where we cannot give the confidence to the patient attenders that there will be good improvement. At the same time, we don't want to miss the chance or lead to not thrombolyze the patient and later they'd end up having worsening, because many times we see that patient comes with 3/5 or 2/5 power in a dense hemiplegia, a capsular infarct, and by next day the patient goes to 0/5 power. So this happened previously, like a week back, with one 6 to 7-year-old lady came. She came around 5 to 6 hours after the stroke. There was 3/5 power on the left side. It was a nice capsular infarct, internal capsular infarct on the right side. We didn't thrombolyze we didn't thrombolyze because the patient had a fall in the bathroom and she had a head injury, even though the CT did not show any SDH or SH. So to not take a risk, she was around 6 hours, so we didn't thrombolyze. But that patient developed complete 0/5 power by next day. So in such cases, I think I would like to know, sir, your ideas what we should do.
Rahul?
I think such small vessel disease, the mechanism many a times is microatheroma or whatever we call it as branch artery disease, as the parent artery. And in such cases, that pontine warning syndrome, whatever we call it as. So many a times the mechanism is because the main artery atherosclerosis blocks the origin of the small vessel or the penetrating artery. And sometimes perfusion related issues and the stuttering course is very common. I think in such strokes, many a times the control of blood pressure, you have to keep the blood pressure little bit on a higher side. That is one more important aspect. Sometimes the role of silestazole as an antiplatelet agent in Asian population has played an important role to prevent the future stuttering. Whether thrombolysis will prevent the stuttering or the progression of the stroke, because many a times this pontine warning or capsular warning syndromes, they go on deteriorating multiple TIs throughout the course, and then suddenly they went on from 3 by 5 power to 0 by 5 power. And such kind of tempo we have seen in such penetrating artery diseases. I think definitely there will be role of thrombolysis, but still relating to dynamics, keeping the blood pressure a little bit on a higher side for first 48 to 72 hours. And uh, these dynamics will play an important role in such kind of strokes. That's what I feel.
So,
Prasanna?
okay.
Prasanna? Hello, Prasanna is there?
Frozen.
Prasanna.
Yeah, but see, Aniruddha, one thing is very clear
Yes, sir.
that
Yes, sir. Yes, sir.
lac-
Yes, sir. Am I audible? Yeah.
Prasanna, one thing is very clear that lacunar infarcts do well with IV thrombolysis. There is no doubt. Whatever the mechanism may be, when they were studied, no thrombolysis and thrombolysis in lacunar infarct, there was benefit in lacunes also, almost 20%, if I remember offhand, cuff. So there is no need to think it is lacunar, therefore I will not thrombolyze. Now the question is, in this capsular warning syndrome, this is another enigma. Now, how to treat this capsular warning syndrome or pontine warning syndrome? There is no proper consensus, but if you see the patient with hemiplegia or deficit, you should thrombolyze this fellow. He may improve and he may worsen again. So that is a problem with this capsular warning syndrome, and the last word has not been written on it. But there is no reason not to thrombolyze these patients because they don't bleed and they may benefit. Now, caveat to this is that, again, the Chinese, when IV thrombolysis is not possible, they have used tirofiban IV, for small vessel disease or even large vessel disease, and they have found benefit. I have not used it upfront like that. But there are reports that, when we don't know the mechanism and it's a small vessel disease like that, tirofiban may be better than IV thrombolysis. Small trials have shown that it is beneficial. I personally haven't used it, but there are some people in South India and all, they have used it and they swear by it. But the jury is out on that. But one thing is very clear, that lacunar infarcts do better with thrombolysis than no thrombolysis. Capsular warning, pontine warning syndrome, of course, they are a problem. They are a problem. They give you terrible headaches because, they get stroke after stroke,
Yeah.
after stroke. So 20 strokes in 3 days, and really you don't know what to do. I've been caught so many times with this, and all of us are suffering from this. But ultimately, though it looks very frightening, ultimately after 1 or 2 months they do improve. They do improve.
पर dense hemiplegia हो जाए
हाँ, they
you are
get
relaxed
20 strokes. They get 20 strokes in 2 days, yeah. Every half an hour, 1 hour, they're getting a stroke. And you have given IV thrombolysis. Again he gets. So it's very frightening at that time. To the family also, it's very frightening. But ultimately, after 1 or 2 months, they come walking.
Yeah.
it is a lacune obviously.
Yeah. So lacunes also, so it is a misconception that it is a small vessel disease, and it is arteriolosclerosis, it is not atheroma, and therefore it will not do well. These are all assumptions that we are. But real world data, if you see that it's data, I'm not talking from my hat. This is data. Data has shown that lacunes do improve with IV thrombolysis. They may not improve as much, but they do improve. So certainly give it. And posterior fossa, as you said, small medullary Wallenberg syndrome, if the vertebral is getting occluded, give it. And maybe you have a longer time window to give it also, because these patients may not come very quickly to you, they don't, they come with vomiting and giddiness, and sometimes you're not sure whether it's a peripheral thing or it's a central thing. MRI does not show the lesion. So when in doubt now, and of course you do that head impulse test. So MRI in posterior fossa may be normal for 24 to 48 hours or 72 hours. So therefore you do the head impulse test and the skew deviation and uh, nystagmus. If you are convinced that it is a central lesion, thrombolyze the patient, because MRI won't show it in the early stage. And my colleague and friend, Dr. Kothari, so he does it very regularly. I am not so confident, but he is very confident. And he's done it many times. And even I've done it few times. So, but MRI, and then you do the MRI after 2-3 days, no? Then you will see the infarct. So don't waste the opportunity. What is going to happen? It's a stroke mimic. Nothing's going to happen. He's not going to bleed and die. But at least stroke mimics also. No, sometimes you can't be sure. This migraine aura, Todd's paralysis. Sometimes history is not available properly. You dig, you do MRI, this, that, diffusion, this, and you are not sure. So in that particular group of patients, and they come at night at 2 o'clock, 3 o'clock, you are also half asleep, you also can't make out properly. So in these patients, it is better to over thrombolize than under thrombolize. At least that is my view. And don't worry, nothing is not going to bleed. Nothing is going to, you may lose a little money, okay, but that is the general view. Of course, you make all effort to see that you are not thrombolizing a stroke mimic, but sometimes you cannot be 100% sure. So in that case, do it.
Sir, we have a question from the audience. Dr. Girish Vadgaonkar is asking, what will be your advice to physicians in periphery where only CT scan is available, and what should be a takeaway from the first case which was presented?
So in that case, Girish, see, you don't need MRI. You don't need MRI. You see a CT scan which does not show a hemorrhage and it does not show a stroke mimic. Thrombolize. You don't need okay, if you have an MRI, you're not sure, do the MRI, fine. You'll waste half an hour, okay. You're paying that price, but CT scan is good enough. Is good enough. If you've got a good CT scan machine and you can do the CT angio, even better. But for CT angio, you need a little higher quality machine, maybe a 32 slice or even 16 slices, okay. But 32 at least, maybe 64, maybe 128. Everyone doesn't have that. But see, what I'm trying to say is that don't deny just because you don't have the equipment. Everyone cannot have MRI. Everyone cannot have CT angio. Everyone cannot have mechanical thrombectomy. That does not mean that you cannot thrombolize. Okay, you may thrombolize little lesser patients. Your confidence level also needs to build up. First, you take only the good cases. Don't take the borderline cases. Take proper cases. Get your confidence up. But use CT scan. Why do you need MRI? You don't need. You have to see clinical radiological mismatch. You have to rule out stroke mimics. You have to rule out hemorrhage. CT does it all. You don't need MRI, especially in the first few hours. I'm not saying 4.5, huh? I don't like to use this word. I would say first few hours. So we want physicians to do it. How many? There are very few neurologists. Neurologists only in the district places and taluka places now a little bit. But other places where Girish Vadgaonkar and people are there, why should you not thrombolize? Do it. We want you to do it. In hilly areas and all, abhi kahan neurologist milne wala hai? You are not going to get. You're not going to get. So don't be so worried. So many cases in Himachal Pradesh, they've been thrombolized by orthopedic surgeons. And if you have a doubt, you send the pictures to this thing on telemedicine. Use telemedicine. Send it on WhatsApp. Within 2 minutes, you'll get an answer. See, you cannot be sure 100%. Nobody in the world can be sure 100%. You take opinion. You send it to Rahul Baviskar, send it to Prasanna, send it to me, send it to 2-3 people. Everyone may not be able to answer you immediately. Send it to 2-3 people. Get an opinion. What is there? They are giving it to you free. We are giving it to you free at any time of the day or night. Somebody will open that WhatsApp and see. And get your confidence up. Once you get your confidence up, you don't need to send. But so for remote areas where only physicians are there, use telemedicine. It works. It works beautifully. Many studies have been done using telemedicine and physical this thing. And they have found that telemedicine works as good as physically seeing the patient. It works as good. And now we have such good telecom infrastructure. You can see videos, you can see the patient fully, you can see his hand, leg, how he's speaking, you can see the CT scan. Why do you need to be physically there? You can't be physically there. You should not be physically there. You can't work 365 days. You can't work. So use this.
Thank you, sir. There's another
Prasanna,
question.
you're not saying anything. Come on. What do you think about this telemedicine and using WhatsApp and all?
100%, sir. 110%. Actually, this is something which I practice actually. There are people
Yeah.
around in taluka places, Pandharpur, Akuluz, Parshi, those people call me and they
Yes.
tell me this is NIHS and what should I do? I just tell them shoot. As simple as just rule out contraindications and shoot off straight off.
Yeah.
So there are so many cases I can count not less than 50 cases wherein I have guided people to encourage them to thrombolize.
Absolutely. That is the absolute correct approach.
Okay. Should there, if there is a bleed, there's something that goes wrong, then send. Then we'll take care.
Occasionally it may go wrong. Yeah, come on now. See,
Yeah.
anyway, even if you don't do now, your mortality is 20 to 25% of stroke. See, everyone will not survive. Some will die. Some will get disabled. We are trying to reduce that disability. We are trying to reduce mortality. We are doing it in good faith. Just do it. And we want physicians to do it. This forum is meant for physicians to do it. How many neurologists are there? Even neurologists know only 1/3 to 1/2 are thrombolizing. All neurologists are not thrombolizing. So you will not get neurologists everywhere. But you use their services on telemedicine. And you have to use this hub and spoke approach. There is a hub and there are spokes. Now, every patient cannot come to the hub. It is not possible. Roads are bad, communication is poor, traffic is there. So in the periphery, in the spoke, you can do it. If there is a problem, you transport the patient. But first you do the thrombolysis in the spoke. And then you can transport the patient if something is required, say decompression is required, or MT is
Absolutely.
required, or something more is required, or ICU care is required, you transport the patient.
Yeah.
But don't waste time in transporting and asking the hub to do the thrombolysis. The
Yeah.
thrombolysis should be done in the spoke. And the hub
Yeah.
should be used for ICU care, decompression, MT, etc. But IVT should be given in the periphery.
That requires to gain confidence, and I think multiple times if you do that, if you
Yes.
gain confidence, if you are confident enough to explain that to the patient,
Yes.
even physician at periphery can easily do thrombolysis.
Yes. There are many physicians in periphery who have done terrific work. Terrific work. One example is this Akluj group. I think they have done more
Akluj,
than
yeah.
350, 400 thrombolysis. And they
Yeah,
are physicians.
easily.
There are
Yeah.
no
Group of physicians.
neurologists there.
No neurologist whatsoever. Yeah.
They are So, it is like cricket. First, you hit the ball in the V only. Then you try all these funny strokes, reverse sweep and scoop and hook and all that. But first, you do the simple cases, get your confidence, take help from the so-called experts, and get your confidence up. Once your confidence is up, you see patients improving in front of you. They bless you. They send you biryani and whiskey bottles. Then your confidence also improves. Then you use all that reverse sweep and double sweep and this and that, and then you can do it. But
The biggest
do it
care
first. Unless you do it, you will not improve.
The biggest care for physicians to do thrombolysis is the medical-legal aspect of it, I think. They have to just...
Now that I want to tell you. So,
Yeah.
medical-legal aspect, person should be sued if in an eligible patient he does not do thrombolysis.
Yeah. Absolutely.
He should be sued in an eligible patient if he does not
responsible for complications.
Yes.
Yeah.
So if a complication occurs, up to now, nowhere in the world they have been sued, but they always won. Nobody has been, the accused has not been incriminated or punished because brain hemorrhage occurred. But people have been sued because in eligible patient, they did not give thrombolysis. So therefore, don't worry about medico-legal issue.
Correct.
Because if you don't do, you are liable. Because it is a FDA-approved treatment. It is approved by Indian Stroke Association. It is approved in India also by whatever the DCGI and all that stuff. It is approved treatment. It is level 1A evidence. And still you don't do it, then you are liable. Yes, there is a small risk of hemorrhage. There is a small risk of death. Yes, we agree. But you will not be sued, or you may be sued, but you will win the case. You will not lose the case. Because it is not medical negligence. It is not medical negligence. But failure of giving appropriate treatment is medical negligence.
Right, sir. Sir, we have another question from Dr. M. Sabir. Sir is asking if tenecteplase is always better than alteplase.
Rahul?
I think the recent trials have at least shown that now. In large vessel occlusion, we know that the recanalization of the vessels have occurred in 30% of cases, as Ichapuria sir rightly said. Then second advantage of tenecteplase is ease of administration. A few seconds bolus, that's it. Within time you can give it. So that is the second advantage. So I think both are equally good. But tenecteplase over a period of time have shown superiority over Actilase. That's what I will say.
Yes. Prasanna, what is
The
your
cost
view?
is also additional factor. Yeah, I fully agree with what Rahul says, but I like to add the factor of cost also. The cost is less as compared to Altiplace, so that most of the people are middle class, lower middle class. You tell them 20,000, you tell them 50,000, that the chance of getting no is much higher if you tell the cost of 50,000. So I mean, Place is one thing where there are more companies now. They are coming up with lesser cost. Even that is something which is going to add to the benefit. Of course, it is as good as Altiplace is. We all know that, but then the cost factor is also very important. That's the only thing which I wanted to add.
I think, sir, even in large vessel occlusions, it is much
it is
better.
superior.
Yeah, large vessel occlusions, bridging
Okay.
therapy, it is much better than Altiplace.
See,
Okay.
all these points which you all have mentioned, cost, ease of administration, and the trials have shown non-inferiority, but the trials were not designed for superiority.
True.
If a trial is designed for superiority, I think it will come up a trumps. But the trial has been designed for non-inferiority. So therefore, we are saying it is non-inferior. But the trial has to be designed for superiority. And that nobody has done that trial. But day-to-day life we are seeing, I think it is superior.
Yeah.
I have no doubt in my mind at all. At times, initially I was a critic. I said, "Kya re baba, trial nahi hai, kaisa denge, how to give." But now I'm a fan. I think Rahul also, you agree? Rahul, Prasanna, you agree?
Yeah, absolutely. Absolutely.
Yeah.
Thank you, sir,
Ronak, we are
for
getting late
validating
now.
our hard work for these many years. And
Huh?
I'm saying thank you very much, sir, for we have been working on this for many years, and I think this is our greatest validation.
No, this is the thing, now I don't know if I should say it, but there is politics involved, there is economics involved, countries are involved. There was when in I think 2017, Kameshwar Prasad in Delhi was
Yes.
advocating it, and there was so much opposition, so much opposition. My God, people were fighting like some mad dogs, over which is better and which is worse. But I think Tenecteplase has stood the test of time.
In
And
last 3 years, I have not used Actilis.
yeah, even I have not used. So we are convinced. At least I am convinced. Yeah, convinced. It's so easy to use. Fadak, you just give it in the CT scan. Within 1 minute, that damn drug is in. Ye to you wala put syringe pump. Now syringe pump everyone doesn't have in periphery. Only big hospitals have syringe pump. Where to get syringe pump in periphery? Where to get syringe pump in ambulance? So
I remember my initial days when I used to thrombolize patient in somebody else's hospital. So we used to stay there for that one entire
yeah,
hour,
yeah,
monitoring the patient.
till that thing goes in, yeah. Here, though, you just fire and forget.
Yeah, correct.
Like BrahMos missile, you just fire and forget. Finished. Work done. So I think we have discussed many things. Aniruddha, you have any other thing to discuss?
Nothing, sir. I got my answers. Yeah.
Yeah.
Thank you.
So thank you, everyone, especially Pramod Donde, Aniruddha, Rahul Baviskar, and Prasanna Kasegaonkar. I think it was a very good and enlightening, at least for me, enlightening discussion, and I'm sure for others also. So back to you, Raunak.
Thank you so much, sir. It was a wonderful discussion. As always, I'm sure it was insightful for all the audience as well. So thank you so much, everyone, for joining in, and good night.
How much audience?
Kalpita?
174.
174.
Okay. Good. Chalo. Thank you. Good night.
Yeah,
Thank you
thank
so
you,
much.
sir.
Good night.
Bye.
Thank you, sir.
Thank you.
I'm ending now, sir.